So thank you. Well, I was going to talk about what's new. I thought an alternative, better title might have been Sex, Drugs and Rock and Roll, and you'll see why in a moment. But I want to just convey the sense that actually the frontotemporal dementia world is a very exciting time as a doctor, as a researcher, and I think for patients and families, things are moving quickly, and we can collectively, as a dementia community, do even more. I've no declarations that are relevant to the material coming today, but this is just for transparency. I want to spend just a minute just clarifying what is frontotemporal dementia and some of the names and terminology. So frontotemporal dementia refers to a family of illnesses. They're very different in their symptoms and signs. Broadly speaking, we've changes in behavior, so the behavioral variant frontotemporal dementia, compared to the language variants, which are properly called primary progressive aphasia. Even within the language variants, they come in different flavors. There's a semantic variant of losing a lot of meanings to words and objects. The agrammatic non-fluent variant, where people's speech becomes telegraphic and distorted and effortful. And there's also what's called a logopenic variant. And that's interesting. It was part of this primary progressive aphasia family, but really we now know it's the language variant of Alzheimer's disease. I'm not going to talk much about that from now on. For the aficionados, if there's neurologists that really like their rare disorders, you may come across things like primary progressive apraxia of speech, for example. And in semantic variant, in terms of clinical populations, usually it's left-sided with a lot of language changes, but you can have the right-sided variant, something called right temporal variant, frontotemporal dementia, that looks a lot like behavioral variant with a change in personality and behavior. That behavioral variant has a very significant overlap with motor neuron disease. So about 20% will have clinically significant changes in their musculature and strength and breathing overlapping motor neuron disease. So it's quite complex in terms of the names, but these are all forms of frontotemporal dementia. I'm going to mention two other diseases that come into the picture. These are perhaps thought of as cousins of frontotemporal dementia. And these illnesses have different names yet again: progressive supranuclear palsy and corticobasal syndrome. And they have they're different biologically, but they have some overlap in terms of symptoms, and there can be some confusion really between them, particularly as time goes by. So there are some differences in the names and symptoms, but what they all have in common is this caused by pathologies that are known as frontotemporal lobar degeneration. It's a family of pathological changes that can land in the language areas or the frontal areas of the brain, giving rise to different symptoms. And I'm going to talk collectively about these over the next 25 minutes. I'm going to basically want you to get to understand that you are never too old for frontotemporal dementia and why that's important. I'm going to talk about a real problem that we're missing women, and also both in research and in clinics. I'll talk about drugs, and I'll talk about why it's such an exciting field to be in and what's coming for the future. So a number of patients that I've been fortunate to look after have gone publicly and chosen through their families to talk openly in the press about living with frontotemporal dementia. So this lady got her symptoms age 30, in the year she got married. This young man's gone public. He's 22 at the moment, and it's a very different kind of illness than when you're 22 at 82, and it brings different challenges for the family. If you follow Hollyoaks, you'll be aware that Luke, one of the big storylines a couple of years back, was Luke with a genetic frontotemporal dementia at all at these very young ages. So it's true to say that most very young onset dementia is frontotemporal dementia. I think that's true. What's not true is the counter statement, which I think has sort of taken hold, that most FTD is young onset. Okay, and I sometimes hear that, or often hear that, and that is not true. Okay, and I'll show you the evidence in a moment. That evidence comes from epidemiology, large-scale studies, looking at patients and who has frontotemporal dementia, what they look like, and how old they are. I'll just take you through that. One of the studies comes from the east of England, so thank you to all those across the east of England who've helped support this study. It's called the PIPIN study. It's been running for 10 years now in 3 phases, and we track every patient we can find in the region and follow them over time. The basics of epidemiology has been published, and I'm going to sort of focus on 2 issues: the age and the sex information. So if we look at the prevalence, how many people are living with the diagnosis per 100,000 of the population, you can see this on the left here, that it rises from the 40s and 50s, peaks in the late 60s, early 70s, and then falls off again. But really that average age, the middle of this body of patients, is around 70. I'm just showing on the right in the pie chart the distributions of the different types of diagnosis that underlie this figure, and that's a fairly even mix of the different types of behavioral language versions, PSP and CPS. If we look at the incidence, the age of getting a new diagnosis, so in blue, we actually see the peak incidence, the peak age of starting your diagnostic journey is around 74, okay? So 74, not young onset at all. We've scaled up. We're part of a European-wide consortium now called Frontiers, looking at all the countries you see here. And we've done a retrospective analysis, again, looking at incidence. And this is what we see here. This is the number of people getting a new diagnosis or newly presenting with FTD by age. And if I put the UK retirement table, 65 there, the health that often uses a marker for old age psychiatry versus adult services, you can clearly see most people, the vast majority of people with frontotemporal dementias are getting their illness in those retirement years over 65. So most frontotemporal dementias are older, roughly 2 per 4 per 100,000 people per year. A lot of people here, almost a third, have family history of dementia, but around 20% of the healthy population will have a family history of dementia as well. It's just such a common problem. Only about 1 in 10 have a strongly autosomal dominant family history. But I think there's lots of people missing. I'd be very interested in why this curve tails off in older age. Biologically, there seems no reason why people should stop getting frontotemporal dementia, like other diseases like Alzheimer's, that you'd expect to just get more and more common. So who are we missing? We're missing these older individuals, and I suspect many of these are just never diagnosed. They go straight to nursing home without a diagnosis. They might get misdiagnosed, but they don't get the correct diagnosis. We're well aware, even in the UK, a number of people are disenfranchised from healthcare services, and particularly with rare or challenging and difficult illnesses like FTD, they might end up in the criminal justice system, they might end up in more general old age psychiatry services without the dementia being recognised for what it is. There may be some people who just decline so rapidly before they can get a diagnosis. But one of the biggest problems is the number of women being missed. So you see here, there's just over half as many women as men in some of these larger epidemiological studies. And the question is why? Okay. If we look in Pippin, where we used multi-source referral, we had neurologists, psychiatrists, electronic health records, nurses, newspaper adverts, the charities helped us, multiple sources of referral. We, over the 10 years, met 520 individual patients, and it's pretty slap on 50-50 men and women. So I think if you really look, there are the women there, equal number of men and women. But the illnesses look a little different. This is recent work from the International Frontotemporal Dementia Prevention Initiative, looking at the types of symptoms by men and women, and whether it's sporadic or genetic. And one of the things to take home, perhaps from the left and right hand radar plots, is those octagons have a different shape. What that tells us is that men and women have slightly different symptoms. Okay, and sometimes it's a very significant difference, particularly looking at 6 o'clock on these radar plots, that degree of compulsivity. So there may be differences in that phenotypic expression. I don't think that's enough to explain the difference. I think there's a lot more going on. My suspicion comes from this other study that looked first in specialist centres, big FTD clinics from different countries, and they looked at sporadic FTD, people who don't have a known gene or a family history, and we find there's almost 2-to-1 male to female ratio. But if you look in people with genetic FTD, you may identify, because you are on the lookout for the illness through that known family history, we find it's almost 50-50. So, that's just, if we're looking in the right way and have a high index of suspicion, the men and women are truly there on equal numbers. So why are the women missing from FTD studies and clinics? Well, it is possible that there are true differences in the causes, the biology, the etiology that affect prevalence or survival. I think it's possible, but the evidence, I think, is lacking. I think there's certainly issues around referral bias, but some of those early symptoms just don't get recognized as a medical issue, which is made worse if people don't recognize that they are ill. One of the common features of frontotemporal dementia is the person with the illness does not feel ill. There's another more insidious problem, which is the way we have operationalized the criteria for diagnosis, talking about a loss of empathy, impulsivity, change in social norms. These may be gendered criteria, not intentionally, but in effect. These may change the way that male versus female symptomatologies are recognized and take someone further for referral. And then there's some practical issues really around research barriers. Again, I'm slightly being a little tongue-in-cheek here, but do wives bring husbands more than husbands bring wives, for example, and other barriers that might just subtly or but pervasively exclude women from research and all that brings. So there is a real challenge here that I don't have all the answers, but I think it's worth us being aware of that. And so the epidemiology suggests equal numbers of men and women, but research in many clinics, I think, are missing them for a variety of reasons. So we talked about age. You're never told for FTD. There should be equal numbers of men and women, but we're not seeing as many men and women as we should. But if we can reach our patients, or they can reach us or you in the healthcare services, how might you treat them? So first thing, think about other dementia drugs, perhaps put in context and what not to use. Essentially, let's think about cholinesterase inhibitors, rivastigmine, donepezil. My advice is do not use these in someone with behavioral variant frontotemporal dementia. There's no evidence that it works, there's no rationale for it's working, and there's a lot of evidence and a lot of personal experience that it can worsen agitation. It can make people more unsettled, more agitated. If you have semantic or non-fluent primary progressive aphasia, I would also say don't use cholinesterase inhibitors. There's no rationale. There isn't a major cholinergic deficit. It's not Alzheimer's disease. There's no trials to support it's effective. I would make the exception, though, for this logopenic variant primary progressive aphasia. People searching and groping for words, often with a prominent anomia. And that's because it is just a version of Alzheimer's disease. So 9 out of 10 people with logopenic variant will have Alzheimer's disease biology. And I think it does make sense to cautiously proceed with cholinesterase inhibitors with all the other usual caveats and monitoring that you would want. What else not to use? I would say do not use a memantine. There's been a clinical trial, good clinical trial, which showed no evidence. Just to show you here, this is the change in the clinical dementia rating scale sum of boxes over a 6-month treatment. And the blue and the red line, placebo and memantine, are very overlapping. There is no effect of memantine. It can only cause problems. So don't use memantine. All right, neuroleptics. These are often used. I would say do not use neuroleptics. Do not use them, do not use them. Or if you absolutely feel you must, use with extreme caution. There's a very high risk of extrapyramidal side effects. These are not always reversible, and they can be associated with a significant increase in mortality. One of the reasons to be so wary of neuroleptics is that half of people with frontotemporal dementia, particularly behavioral variant, I should say, develop Parkinsonism, as significant Parkinsonism, as part of the illness. So you would no more want to use neuroleptics in someone with frontotemporal dementia than you would with someone with Parkinson's disease. Okay? You're just going to have a very, very high risk of severe, perhaps irreversible extrapyramidal side effects. If there's an immediate risk to life and limb, and you really feel this is a safety issue and you have to use something short-term to get through a crisis, then I do personally use sometimes low-dose quetiapine, 12.5, perhaps 25 milligrams a day. This is much lower doses than you may use in other contexts. Occasionally, very small doses of risperidone, 0.25, perhaps half a milligram. The difference is, though, you have to advise the next of kin what to look out for in terms of extrapyramidal symptoms, and you need to monitor closely and be willing to take people off. You cannot just prescribe it and then send someone off and hope that they'll come back via the GP if there's a problem, because it's quite a high-risk strategy to treat with neuroleptics. Occasionally, you need it in a very high-risk situation, but I would really urge extreme caution. Let's think about other things that you might be able to treat. Well, there's a wide range of aspects of frontotemporal dementia that I think are eminently treatable, that you can help make a substantial difference to the patient's safety, perhaps the patient's symptoms, and certainly the family burden and stress, and perhaps even long-term risks. So disinhibited behavior, impulsivity, and also pseudobulbar affect, this pathological laughter and crying without low mood. These can all respond well to SSRIs. Even in the absence of depression, the absence of anxiety, this is not a mood effect of the SSRI. It's around the role of serotonin in behavioral control. I'll talk about a clinical trial of citalopram in a few minutes, but anecdotally at the moment, I would tend to reach for SSRIs, occasionally trazodone. Sometimes the sedating effect of trazodone can get you through a crisis in a short term, but you do need to be aware that sedation is also problematic. Psychosis, again, as perhaps with any other features inside the sort of neuropsychiatric space, assess the risks, think about non-drug options, think about the significance of that psychotic phenomenon. Be aware it may be visual, not commonly, I would say. Much more common is to get somatic delusions, body part missing, creatures under the skin, somatization, declaring pain or symptoms in a body part, which doesn't seem to match reality as others would observe it. And it can be a paranoid delusions of infidelity, for example. And you need to think about how disruptive these are for the patient and their families before treating. If you need a drug treatment, I would always suggest start low and go slow. Tiny doses of risperidone, small doses of quetiapine or aripiprazole. Thing to definitely avoid are haloperidol and those old-fashioned neuroleptics. You're very much likely to do more harm than good. But psychosis is manageable. It's not very common, but it's certainly manageable. It tends not to last forever. It tends to be present perhaps for 6 or 12 months and then seems to burn out for most patients, even as other aspects of the illness get worse. Sexual behaviours and sexual risk, I think these cause a lot of distress, a lot of concern in families. It's actually relatively unusual that there's any sexual acting out with physical contact. Tend to be more lewd remarks, which can be upsetting, but they tend not to prevent a direct physical threat. Actually, in some ways more important to protect the patient who may get into trouble by making sexually oriented comments. It's very important to protect that patient from harm from other people. But the best way to manage these is through the environment, anticipating and preventing situations that may provoke comments or distress. I say environment, psychological support, particularly around the carer, how to anticipate and divert these difficult behaviours. If it's not avoidable and you really feel you have to reach for the pharmacological treatment, then some of the SSRIs, particularly paroxetine, may induce a more sort of asexual abulia, which may tip the balance. Think also about treating the disinhibited behavior. So it's not just the sexual nature of the behaviors, it's the fact that it's said in an inappropriate context or said out of turn. So it comes back to thinking of it as an inhibitory problem, not a sexual problem itself. Very distressing when it occurs, but is manageable and can be diverted and tends to die away of its own accord over time. Sleep disorders, also very disruptive, exhausting for carers, very disruptive for care homes. Usual things first: good sleep hygiene, non-pharmacological measures around fluids and caffeine, and screens late at night, and just good sleep hygiene, and trying to mitigate the risk of people being up and wandering at night. So these are non-pharmacological measures that I think are an absolute priority, but there can be some benefit from melatonin, late evening melatonin, 2, 4, 6 milligrams in the late evening, and benzodiazepines or zolpidem and zopiclone can also be helpful. Strangely, I find many patients tend not to get very sleepy with standard doses of benzodiazepines, and there is a risk of sedation when people are up around at night or in the next day. So they're not uncomplicated, but modest doses of benzodiazepine Z drugs can be helpful, but only after you've dealt with the non-drug measures first. And the other aspect, of course, is not all around drugs. Well, I've got the slide saying drug options. There's a lot to think about with nutrition and dysphagia risk, communication aids, and mitigating the consequences of the illness around falls and falls risk, particularly in older adults, how you manage comorbid things like diabetes in the presence of the dementia, and protecting the medical, the legal, and the financial well-being of a patient and their family through some of the medical legal steps that you can take. So there's an awful lot one can do, even now with current treatments, current service supports to help patients and families. To know what to do, I always think you need to think in sort of three parts. Think about what bothers a patient. We often say patients lack insight, or they may have anosognosia. That's not entirely true. I think they have a different insight. There may be aspects of the illness that bother them, and the more you can do to focus on what bothers them, the better the engagement and cooperation you'll have from the patient. You just have to recognize it may be different to the problems that bother the family, which need separate prioritization, perhaps a separate management strategy. And what you need to think about too, as whether it's a specialist nurse or a doctor, psychiatrist, is think about what lies ahead. So thinking ahead about risks, nutrition, falls, medical legal aspects at the same time. So think on these 3 different levels, you'll find there's an awful lot you can do. In the last few minutes, I want to touch on research and what lies ahead for the future. A lot of this is building on the genetic aspects of FTD. So if one thinks about people with behavioural variant frontotemporal dementia, for example, if you took 100 people as I summarise on screen here. About a third, maybe 40%, have a family history of someone else with dementia. And about half of them will have a gene that can be identified, one of these common genes, seen on off mapped for progranulin TBK1. These make up a significant proportion, 10 to 15% of people with behavioural variant frontotemporal dementia. And it's worth finding. They're very easy now to look for genes. This is diagnostic testing, not about prediction of healthy adults where they might get dementia, but an adult who has the dementia, and you're asking what's caused it. It's a single blood test. On the NHS England genomics form, you put the R58 code, and that will cover pretty much every gene you need to worry about. Nice and simple, R58 is the code, and they'll then go through a whole panel of genes. You don't need to try and be clever and match particular genes for particular symptoms. Just put R58. And the reason for that is that we're now in a very exciting phase of potentially curative and after that preventative treatments. So many companies around the world are engaged in trials that have either just completed or are currently ongoing. And they're using such a wide range of technologies that I don't know which of these will work, but between them, there's a very high chance of breaking through, whether these are these antisense oligonucleotides, these little snippets of anti-DNA that can neutralize the mutated gene, monoclonal antibodies that have been designed again to neutralize the aberrant products of those faulty genes, cell therapies, viral vectors trying to do gene replacement therapies, which the virus can carry in the gene, such as the progranulin, or some classic drugs and small molecules. These are all in clinical trials in patients. One of these, the Electra trial, the biggest of these at the moment, has had its last patient in. It's a phase 3 trial, so if this works, it has regulatory potential to get a definitive drug license for treatment. Over 100 people with symptoms and others who are carriers coming up for their symptoms. From the baseline data, they just look like typical patients, and it's really exciting. The trial is due to end, so the last patient's already in the trial 18 months ago. The last patient has their last dose in a couple of months, and so we can look forward to the autumn to know whether this has worked or not. So this is a very exciting phase for FTD, and there are half a dozen other trials ongoing. For such trials, you need to know the gene for the gene-based therapy, and we need to be much more liberal around testing. There's a very nice review article here in the JNMP article a couple of years back that summarizes some of the issues, but it basically says, as a community, we're not testing people enough. Okay? We know that if we'd followed the standard genetic guidance on who to test and when, we would have missed half of our FTD patients in the Cambridgeshire region who we know to have a pathogenic mutation. Okay? So the genetic guidance are just too conservative at the moment. And my advice would be to discuss and raise the issue of genetics testing with everybody with the young onset dementias under 65. There's a significant positive rate that opens up some really important discussions around management, prognostication, some of the trials that are coming, and managing family risks for the future. It's very empowering and positive information if it's handled in the right way for families. And I'd say if you've got behavioural variant frontotemporal dementia, genotype anyone of any age, because there's a very strong 5 or 10% positivity rate, even in sporadic disease without a family history. Okay. So that's that R58 codes, all you need to know for that. Looking ahead, I'm going to just highlight a new, very exciting national network in the UK. This is led by my colleague Marat Malpetti, called the Open Network for Frontotemporal Dementia Information, really looking at blood-based biomarkers. I'm sure many of you will recognise your centres on the slide here. We're now getting these centres up and running through their site initiation visits, and this is to become an open resource for academics, healthcare services and industry partners to really accelerate research towards new treatments for frontotemporal dementia. And there's a new trial coming up, which has now been funded, which is a clinical trial of citalopram versus placebo to help in people with frontotemporal dementia, any clinical variant, if they have those problems of impulsivity and disruptive behaviours. So my colleague Dr. Alex Murley is leading this, and we hope to be able to launch this more publicly, more actively in the autumn this year. So just to summarise in the last 2 minutes, on age, you're never too old for frontotemporal dementia. Most people's frontotemporal dementia begins after the age of 65. Men and women get frontotemporal dementia equally, but it seems that in a lot of our clinical services and a lot of research, we're missing women, and there's reasons for that that are not entirely understood and certainly not resolved. But just be aware of that. Be more sensitive to the possibility of underdiagnosing women in your region. classic drug options that you might use in Alzheimer's disease, basically not indicated for frontotemporal dementia, but there are other drug options I've touched on briefly around other symptom problems, impulsivity, sleep psychosis, bladder problems, and the long-term fallout of the illness around falls and fracture risks, nutrition, and so on. So there's actually a lot of active treatments we can do already. And it's such an exciting time with clinical trials of potentially definitive, I might even say curative treatments for those with gene mutations for FTD, but also symptomatic trials for patients with sporadic, the most common forms of frontotemporal dementia coming shortly. So thank you for listening. I just wanted to give a shout out to the fantastic team I've got both here in Cambridge at the Centre for Frontotemporal Dementias and colleagues around the UK, including some of those online I can see when I look at the list, and around the rest of the world. So thank you very much indeed for listening, and I'll be delighted to take any questions.